West Nile viral infection is disease caused by virus of flaviviral genus, mainly transmitted by bite of infected mosquito. Most human West Nile viral infections are asymptomatic. Approximately 20% of infected develop febrile infection or West Nile fever, while in less than 1% infection progress to neuroinvasive disease or West Nile neuroinvasive disease with manifestations of meningitis, encephalitis, and acute flaccid paralysis. Although West Nile viral infection in humans has not been previously documented, nevertheless, 4 surveys carried out in Serbian districts between 2007 and 2012 revealed presence of West Nile viral antibodies in human, horses, and bird population, and West Nile viral RNA in mosquitoes. Taking in account those results and transmission of West Nile virus in neighboring country Hungary and Romania, enhanced West Nile viral infection surveillance was established in humans in 2012. First outbreak occurred in 2013. We investigated this outbreak to assess its extent and to identify determinants associated with West Nile neuroinvasive disease and fatal outcome. Surveillance data are used in this investigation. Enhanced surveillance is conducted across the whole country during West Nile viral activity season that in Serbia, according to latitude, is from June to mid-November, and passive surveillance out of that time. 24 hours after case identification, information on demographics, clinical manifestations, and underlying chronic medical conditions were collected on standardized case investigation form by epidemiologists of district CDCs. During epidemiological investigation, sera and cerebrospinal fluid specimens are analyzed for presence of West Nile viral IgM and IgG antibodies. We calculated attack rates and we stratified those by demographics. We calculated also risk ratios to compare attack rates. Multiple regression models were constructed to identify determinants associated with fatal outcome. 2008 EU case definition is in use in Serbia. Cases were classified as probable and confirmed according to clinical and laboratory criteria. For the former, specific antibody response in sera was determined, and for the later one, IgM antibody in cerebrospinal fluid specimen. Data flow is organized from acute care hospitals through district CDCs and reference laboratory for arboviruses to Serbian CDC. Serbian CDC, National Coordinating Center for Surveillance, established in National Institute of Public Health, works with network of 23 district CDCs established in district institutes of public health. Overall, 303 cases of West Nile viral infection were reported to Serbian CDC. Of those, 247 had neuroinvasive disease with manifestations of meningitis, encephalitis, and acute flaccid paralysis, and were classified as West Nile neuroinvasive disease cases. Another 56 were considered as non-West Nile neuroinvasive disease cases. Encephalitis, meningoencephalitis, was the most prominent clinical syndrome among patients with West Nile neuroinvasive disease, followed by meningitis. A large proportion of patients had underlying chronic medical condition. The most common was hypertension, almost half of them. Each fifth had heart disease, and each fourth diabetes. Case fatality rate was 13%. All cases occurred within 18 weeks time interval, from June 25th, week 26th, to November 2nd, week 44th. The outbreak peaked third week of August. By November 2nd, 247 laboratory diagnosed cases of West Nile neuroinvasive disease were reported to Serbian CDC. Cases were reported from 15 out of 25 Serbian districts. Attack rates ranged between 0.3 and 14.1 per 100,000 population. North and central Serbian districts were affected. Stratification by age, gender, and living place has shown that attack rates increased progressively with age and male gender. Cases older of 70 years were 27 times more likely to develop West Nile neuroinvasive disease compared to cases younger of 30 years. Males were 78% more likely to develop disease compared to females. Statistical difference was not found between attack rates in rural and urban areas. We performed univariate and multivariable analysis, and we found that age over 80 was independent predictor of fatal outcome. On this table are presented only statistically significant variables. Control measures included health promotional activities and enhanced larval and adult mosquito control. In current outbreak, West Nile neuroinvasive disease more severely affected elderly male population. Elderly was also negative prognostic determinant for fatal outcome. Outbreak occurred in North and Central Serbian districts in areas hosting wild, resident, and migratory birds because of containing high percentages of agricultural land and river water basin. In this investigation, limitation is that cases with mild West Nile viral infection were identified and reported less likely because by enhanced surveillance, severe ones are presented. And at the end, we recommend. During transmission season, we recommend raising awareness among health professionals and health promotional activities among general and elderly population. In affected areas, we recommend establishment of West Nile viral infection surveillance in horse and bird population by veterinarian sector, and establishment of comprehensive mosquito control by agriculture sector, as well as establishment of blood safety measures by health sector. My acknowledgement to all co-workers, and thank you very much for your attention.
Thank you very much, Dr. Mitra, for this excellent presentation and excellent investigation of this outbreak. I would like to ask you if you have some questions to Dr. Mitra.
Thank you, Mitra, for your nice presentation. I just small comment. When you start your presentation, when you describe the disease of West Nile, you put less than 1% you have the neurologic complication, and maybe 20% this is fever. But when you look your result, you find a lot of case neurological and less for fever. Is linked for criteria for selection or what? Just explain it. Thank you.
As I have understood, your question was why we have so less West Nile fever, yeah? Yes, this was as in our study and in all published study, it is mentioned because of severity of disease and consistency of symptoms is more often reported and diagnosed West Nile neuroinvasive disease. That is one explanation.
Dr. Drakulovic, thank you very much for nice presentations.
My pleasure.
I have a question. In the last slides, between the recommendations was mentioned that you propose, based on the results, blood safety measures. Can you list what
Sorry, I didn't hear well.
Blood safety measures, one of the recommendations. What kind of safety measures you proposed based on your results? Thank you.
I have those on the slide. We propose deferral for now of blood donation for 28 years. If patients or if donors have visited affected areas, and we perform interview with donors about some fever-like diseases, and I have another measures that are not proposed that are not carried out in my country. They are not carried out in that time in 2013. Thank you.
And I would like to tell you that, as you remember, during the vector-borne disease, this case study was used to construct a case study for fellows, and I would like to thank our colleagues from Serbia to give us this chance to learn from this outbreak investigation. Congratulations for this hard work.
It was my pleasure. Thank you.